Hello, and welcome to week 3 class. I'm doing something different today. I'm attempting to do this on Zoom so that I can share some documents here with you as I get settled in. So what we're looking at today are 2 chapters. I also want to talk about the upcoming motivational interviewing assignment. So you want to stay tuned for that. However, I'm saving that to the end to get you to listen to the entire video. Uh, Chapter 7 talks about screening and assessment. And these are 2 very important tools. And there's a difference, and people don't always recognize the difference between the 2. Screening, as the book tells us on page 297, are tools that help detect the possibility of a problem. So what they are doing is they are screening a person either in or out for having a substance abuse problem. So they might be determined using the DSM-5 categories that we talked about, the DSM criteria. You would look to see if a person might have a problem. And the book gives us several examples, screening tools, one being CAGE, C-A-G-E, with C being, have you ever felt you ought to cut down your drinking or drug use? A, have people annoyed you by criticizing your alcohol or drug use? G, have you ever felt bad or guilty about your alcohol or drug use? And E, have you ever had a drink or a drug early in the morning? Now, an answer yes to any of these things may not indicate that the person has a problem, but it does indicate that you will want to then look further and to assess whether or not the person has a problem, and if so, how much of a problem it is. It also gives the TWEAK, which is 5 questions. The first one is about tolerance. How many drinks or how much, how many hits or whatever does it take for you to get the feeling you want? W is for worried. Have you ever had friends or relatives worried or complaining about your use? E for eye opener. Have you ever had uh, something in the morning to get you started on your day? A for amnesia. Have people told you about things you've done and said after the fact that you don't remember doing? And K, unfortunately, is for cut down. Did somebody ever tell you express to you the need for you to cut down on how much you were using? So again, like I say, with assessment tools, with screening tools, all you're trying to do is say, okay, we need to look closer at this. If a person is screened in for a possibility of a problem, then you need to further assess, is there a problem? And if so, what level is the problem? And it gives you a number of assessment tools. On page 300 is the Gamblers Anonymous 20 questions. It talks about assessing levels of care. And I've talked about this before when we talked about the DSM-5 criteria and the levels of substance use disorder, mild, moderate, and severe. And you want to make sure you are providing the appropriate care for the situation. And it talks about some simple screening tools like the simple screening instrument for substance abuse, self-administered form. It talks about the MAST, it's a Michigan alcohol severity test. Uh, and the problem with a lot of these is that they are very transparent. And a person who is given this knows pretty much what answers will make them look good or perhaps so. You need a lot more information than that, but it at least gives you some idea of what might be going on. Assessment is very tricky, and generally, as a person enters treatment, we do a very thorough biopsychosocial assessment, which may include using an assessment tool like the MAST, or some people will use things like the SASI, the Substance Abuse Subtle Screening Inventory. But it also asks an awful lot of questions about the person's personal history, about their psychological health, about their physical health, their legal issues, their social issues. And all of these things together help us to determine whether or not the person needs treatment, and if so, what level of treatment they might need. So that is a skimming of Chapter 7. Chapter 8, Strength and Evidence-Based Helping Strategies. Now we start to really get into some of the nuts and bolts of how we treat substance use disorder. And one of the first things it talks about is harm reduction. And harm reduction, again, can be a very controversial approach, but it is sometimes the best approach to use because we need to meet the person coming into treatment where they are at. And they may not be ready to commit to full abstinence and sobriety, but they may be ready to commit to medication. They may be willing to commit to using clean needles, or they may be ready to commit to having a safe place to use drugs. Somebody can watch and make sure that they don't overdose. And while these are not ideal, it's where the person is. And if you can get them in and get them engaged in the process, then we have a much better chance of getting the person uh, involved in the full treatment that we would like them to have. So that then leads us to our next uh, part of treatment, which is motivational interviewing. To understand motivational interviewing, we really need to go back to page 271. And on page 271, at the top of the page, there's table 6.1, which is stage-specific motivational statements. And here it lists 5 stages. What I want to try to do is see if I can bring up this slide. And let's see, we will start, hopefully, the slideshow from this slide. So here we have the 5 stages of change. These were developed by Miller and Rolnick. No, I take that back. Prochaska and DiClemente developed the stages of change. And you can see on the chart here, there are 5. There's pre-contemplation. And in pre-contemplation, the person does not yet recognize or feel that they have a problem. Uh, they are pretty much convinced that there is nothing wrong. People are perhaps oversensitive, people are overworried, whatever. When you get to the next stage, which is contemplation, the person begins to say, maybe something's wrong. Yeah, I can kind of see where there might be a problem here. Yeah, this is sort of starting to feel like it's getting out of hand. The third stage is preparation, where the person starts to say, if I'm going to change, what do I need to do? What needs to happen? What skills might I need? What help might I need? The fourth stage is action. And that's where the person actually begins to make the change. That is usually considered to be about 6 months. Then you move into the maintenance stage where you keep that change going. And you notice they have an arrow between the maintenance, the pre-contemplation. It doesn't really generally work that way, or at least need to work that way that a person goes back into pre-contemplation. Maintenance is considered to last for about 6 months. And really, after that, you're just kind of in continuing recovery. Now, I want to point out that on this chart, and actually in the model of stages of change, relapse is not a stage of change. Relapse is moving away from change back to previous behavior. My problem with the emphasis on relapse that you find in the addiction treatment field is that it is often presented, perhaps unwittingly, in a way that makes people feel like you have to relapse. That relapse, in fact, I've heard people being told in treatment that relapse is a part of recovery. Relapse is something that can happen, but it is not a part of recovery. It does not need to be a part of recovery. In my own practice, rather than focusing on relapse, I focused on building and maintaining recovery, which had the person focused on positive change rather than fear of failure. And I think it's a much healthier way to look at it. So motivational interviewing, which this chapter talks about, are a series of ideas and techniques that help to move the person through the stages of change. It's an evidence-based practice, which means that there have been clinical trials that show that this works. Because it is an evidence-based practice, most insurance companies want you to use these type of approaches. It offers an alternative to confrontation, which confrontation can strengthen the client's denial. And it's based on the stages of change model, developed by Prochaska and Carlo Di Clemente. You'll want to particularly understand the stages of change in motivational interviewing as you do the assignment that's coming up over the next couple of weeks. The book goes on to give you techniques for enhancing motivation, closing the deal, motivational enhancement therapy. It goes on to talk about solution-focused therapy, which is rather than being focused on the problem, oh, you have an addiction, it is focused on you want your life to be better. You are looking for this in your life, and let's move you to that. So again, it's not focused on the problem, it's focused on the solution. The next thing that the talks about is cognitive behavioral therapy. And cognitive behavioral therapy is another of those techniques that insurance companies are really looking for people. There's several forms of cognitive behavioral therapy. I'm particularly fond of the rational motive behavior therapy developed by Albert Ellis. It's an excellent tool for cognitive behavioral change. And it's used by 12-step based treatment programs as well as in Smart Recovery. And one reason I like this model is it's very easy to remember because Ellis developed it on an alphabetical model. So I'm going to briefly go through the basics of rational motive behavior therapy. So what happens is there's an activating event. Something happens. And then as a result of that, there's a consequence for a reaction. So Albert Ellis, in looking at this, asks the question, is the person responding directly to what happened? And my first thought, when I first heard about this, was, well, of course they are. So he presents a nice illustration. You have a group of students who walk into the classroom, and the teacher says, we're going to have a pop quiz. Now, you've got some students who have really studied hard, and they're going to say, boy, I'm going to ace this. You know, my parents are going to be proud. And you've got some other students who maybe haven't even opened a textbook, and their response is going to be, this is horrible. I'm going to fail. I'm going to flunk out of class. You know, my family's going to disown me. And then you might have a third group of students who will say, well, that's not fair. The Constitution says you have to tell us ahead of time we're going to have a test. So Ellis said, you've got the same thing happening to all these people, but you have different consequences, different reactions. He said it's because they're not relating, they're not responding to what happened, but what they believe about what happened. So if your belief is, I've studied hard, I'll do well, you have one reaction. If your belief is, well, I've been goofing off and I'm in trouble, you have a different reaction. If you think the life is unfair and everybody is out to get you, you have another reaction. So the trouble is that sometimes our belief is not rational. If you have studied hard and done all the work, but your first reaction is, oh no, I'm going to fail, this is terrible, I can't do anything, that belief is not rational. And as a result, you're going to have an irrational consequence. So what Ellis suggests is that we need to first recognize these irrational beliefs, then we have to start dealing with them. And we do that by using disputing techniques. So when you find yourself thinking, oh no, this is terrible, I can't do this, you start to say, you know, you've done all the reading, you've studied hard, you've been doing study guides for the last 3 weeks, you are going to do fine on this test. And by the way, there are no pop quizzes on this course, so don't worry about that. But you've got this disputing technique. So when you start to feel that irrational reaction, you start saying, no, wait a minute. Here is what's really happening. And what that does is that leads to a new effect. You, instead of having the irrational consequence, you have a new effect or a new consequence, a new reaction. You say, okay, I wasn't expecting this, but I can handle it. When you respond to something in a rational way, when you respond irrationally, after a while, you really begin to then feel bad for having had an irrational reaction. You may feel like, you acted foolishly. You may have acted immature. You may have been nasty to people. When you learn how to dispute irrational beliefs, you get that new effect, that new consequence. It also leads to a new feeling, and you walk away from it feeling good. Let me see if the next slide applies. Yeah. So here's some common irrational beliefs in recovery. One is that abstinence is a curse. It's not fair that others can use and I can't. Drinking, drugging is not a problem for me. Other people have a problem with my using. Sobriety is just too hard. I might be bored, lose friends, or be uncomfortable. Not stand to have another drink or drug. So these are all common irrational beliefs. And when we can get people to start to recognize those irrational beliefs, we then can begin to get people to move further along the recovery. So that is a brief overview of chapter 8. And again, I think this is one of the most important chapters in terms of really understanding what treatment is all about. So I want to move into talking about the uh, paper that's coming up. And I'm going to again share my screen here with you. And let me see if I can. That's the wrong thing. Let me look again. Stop sharing this. And let me. That's what I want. Okay. So here is the instructions for the next paper. So it says, as you can read, review the information for your client below and answer the following questions. What are the client's strengths? List at least 5. Describe how these strengths could aid your client during treatment. Some strengths will be very obvious. Others you may have to dig for. But it's really important that, number one, clients recognize their strengths. But a lot of times when I do an assessment with a new client, one of the questions we ask are, what are your strengths? And a lot of people have difficulty answering that question. So we need to learn to identify strengths, point them out to our clients if they're not able to see them. So this part of the activity, uh, be creative, do some digging, look at things and ask yourself, how could this be a strength? Uh, they have children. How can that be a strength? They have a job. How can that be a strength? So it really starts to train you to look at your person that you're working with and finding and pointing out their strengths to them. The second thing you're going to answer, you're going to describe some of the potential barriers that may impact the person's treatment. What are the social, cultural, or environmental factors? They increase or decrease their level of risk. For each potential barrier, describe what you could do, implement, or provide to help increase protective factors. So it's one thing to identify a barrier, but we also have to help the client to identify ways of dealing with those barriers. And again, it is giving them, helping them to develop more strength. Then, according to Prochaska's model of change, how would you describe the client's motivation to change? What level of the stages of change do you feel this person is at? And keep in mind, again, the 5 stages of change are pre-contemplation, contemplation, preparation, action, and maintenance. So when you're answering this question, you will want to use one of those 5 things. Please do not say they are in the relapse stage, because that is not a stage of change. Don't tell me they're at step 3, because that is not a stage of change. It needs to be one of those 5 stages of change. And it's not important. I don't necessarily feel that there is a right or wrong answer to that. What is important is to explain how you decided what stage of change they were at. So I will not say, oh, you gave the wrong stage. As long as you can tell me why you feel that that is the stage of change that the person is at. Then you're going to go to the resource guide, which is listed in under the assignment. And actually, let's see if we can get into that. Um, here anyway. Okay, so but you're going to look at this guide and you're going to determine places that the person might go for treatment. Choose an area where you would like the person to be living and find things along around that area. The guide covers most of Western Mass, the central Western Mass, through Holyoke, Springfield, even over into to Ware and areas like that. So how do you know which person you're going to work on? Here's the breakdown. If your last name starts with A to H, you're going to work on client A. With I to R, you'll do client B. S to Z, you'll do client C. Now, here's what throws some people off. They start saying, well, where do I find these people? The trick is that even though there's a lot of blank space here, you have to keep scrolling down to the second page. So here you'll find your client, and it gives you information about the person. And then based on this information, you are going to answer those questions. And again, it may require you to do some thinking uh, and to do some digging and to be imaginative. But I can assure you, particularly with strengths, that you can easily find 5 strengths for you. Let me see if I can get into uh, and actually that I think is the wrong one. All right, let me see here. Okay, here's the treatment guide. So we'll make this just a little bit larger. This is put out by the Quabog Hills uh, Community Coalition. And you'll see it has detoxification services, hospitals, emergency services, crisis centers, substance use and recovery counselors, substance use and recovery counselors for youth, resources for youth, so on and so forth, including things like pain management, recovery learning communities, domestic violence resources, hotlines, warm lines, even educational resources and basic needs. Uh, you can see, for instance, uh, these are substance use and recovery counselors. Uh, and we'll go way down here. Uh, you'll find, like the Department of Transitional Services, Mass Health Enrollment. Uh, so this guide will help you to complete that assignment. So that's our overview of the 2 chapters for this week and the upcoming assignment. And I wish you the best this week. I look forward to your discussions and look forward to seeing you again soon. Have a good day.